Case 1. The first patient was a tall young woman and I immediately suspected this to be a Marfan's syndrome. Sure enough, her anterior segment examination revealed bilateral contact lens, wherefore aphakia in both eyes. I was asked to look for other signs of Marfan's syndrome in her. She had arachnodactyly, high arch, palate, arm span longer than height. I also mentioned that I would like to carry out a cardiovascular examination. The examiner asked me what medication would I give to Marfan's patient with cardiovascular problems. Case 2. This was visual field examination using confrontation method. I wanted to start the test by presenting finger in different quadrants, but the examiner stopped me and asked me to test the field with a white pin. There was bitemporal superior quadrinopia. I was asked about the systemic manifestation of pituitary problems, i.e. galactorrhea, loss of hair, and libido in men and infertility in women.
Did you ever think of getting a cataract surgery fellowship in India? But we're confused as to which college or hospital is the best. Which city is the safest? Will there be accommodation provided? Whether you will be provided reliable transportation services from and to the airport along with clean food and water for the duration of your trip. I am Dr. Abid Nawaz, and I had all the same questions and I faced many of the same problems, which is why I started a service to help future fellows wanting to do their fellowships in India. Head over to phaconetwork.com and snag your free consultation with me and my amazing team. We'll help you find the perfect fellowship that matches your vibe, letting you train with certified pros at some of the coolest hospitals in India. Did I mention it's completely free? Level up your skills and kickstart your surgical ophthalmology journey with us. Let's make it happen. FACO Network. Let's go.
Case 3. The patient had bilateral prominent eyes suggestive of thyroid eye disease. The examiners wanted me to examine the patient as if she was first seen in the consultation clinic. They were especially interested to know how I would test the optic nerve function, afferent pupillary defect, visual field, color vision and direct visualization of the disc, the type of thyroid function tests and antibodies I would order. There was also a brief discussion of differential diagnosis of proptosis, vitreous hemorrhage. Case 4. I was asked to examine the fundus of a patient with an instrument of my choice. I opted for slit lamp using the 90D. In the right eye, there was extensive panphotocoagulation with new vessels. Elsewhere, some of the scars were white, suggesting recent fill-in laser. The left fundus cannot be visualized due to vitreous hemorrhage. The examiners asked me for the differential diagnosis of vitreous hemorrhage. Case 1. I was asked to examine the anterior segment of a woman in her 70s with a slit lamp. She had had a right trabeculectomy and advanced cupping in this eye. There were no signs of pseudoexfoliation syndrome or other secondary changes. I diagnosed primary open-angle glaucoma. I was grilled on the different types of anti-glaucoma treatment and their side effects. Case 2. Again a slit lamp examination. The patient had a left lamellar keratoplasty. There was no other signs to suggest the reason for the graft. I was asked about the post-operative management of corneal graft and the advantages and disadvantages of lamellar versus penetrating keratoplasty. Case 3. Fundal examination using a 90D lens. The patient had a grayish lesion which is slightly elevated, located in the periphery of the left posterior segment. Questions on the differential diagnosis and Treatment options for choroidal melanoma. Case 4. This is again a slit lamp examination. The patient had a right iridodialysis and stellate cataract. Capital I. Made a diagnosis of blunt ocular trauma. I asked to examine the posterior segment for choroidal rupture and possible retinal changes from detachment surgery. However, there were no such changes when I examined the fundus with a 90D lens. One of the examiners asked me about the management of traumatic hyphema and the possible causes of raised intraocular pressures following blunt trauma. Case 1. I was asked to examine the anterior segment of a young girl with thick plus lenses. I found bilateral aphakia and told the examiner that I suspected that she may have Marfan's syndrome. I was asked about the characteristic features of Marfan's syndrome which this patient had in abundance. I was asked to listen to her chest and she had signs of diastolic murmur and I gave a differential diagnosis of aortic valve incompetence and aortic root dilatation. I was asked what medication I would prescribe the patient, and I suggested beta blockers and the examiner seemed satisfied with the answer.
Case 2. The patient was a young woman with a dilated left pupil and I was asked to perform pupillary examination. There was light near dissociation. I diagnosed a dized pupil and told the examiner that I would also like to examine the left iris on the slit lamp for vermiform movement and also test the patient's tendon reflexes for signs of Holm-Dice syndrome. The examiners then asked about the differential diagnosis of light near dissociation. Most of the questions centered on Argyle Robertson's pupils and the site of the lesion. Then I was asked how syphilis can affect the eye.